will happen because we believe in conservative, rather than COVID making us do it conservative. Do you think that is a correct statement?
No, I'm not quite sure there, Dr. Maheshwari, but I think a lot of people were quite conservative initially for proximal humeral fracture. Now, as you said, there was a fashion and there was a lot of push for these marvelous plates and nails, and then people got swayed a little. However, people didn't, they thought that the surgery was giving better results. Now we have a bit more research and a bit more information. So now we are not ashamed to push conservative surgery because of the PROFA trial. I can tell patients there is evidence to say that some of these fractures which are not grossly displaced, if I treat you non-operatively, you will get as good a result as surgery. So now there is some evidence to say that a lot of these patients where you are in equipoise, surgery will not necessarily give you better results. So you are talking of evidence here.
So any comments from other panelists?
Can I ask a question?
Yeah.
Radhakant, what I understood from the PROFA trial is that the inclusion criterion was that it regards patients, well, that the exclusion criteria was that patient you should operate it without any doubt, they were excluded.
Yeah.
And can you tell me in your practice and your philosophy, which patient you should treat surgically anyway?
So as I showed you a few x-rays, I'll just go back.
That's a very good question to clarify PROFA trial. People tend to believe that PROFA trial has said, okay, whether you operate or don't operate doesn't matter. That's not
correct. That's completely wrong. So this is a fracture which you see the tuberosity is completely off. And this is a younger patient.
Yes.
And if you say, okay, this is a patient who's 40 years of age and the tuberosity is completely off, I would like to operate on them. PROFA trial says that's okay. This is a fracture dislocation. Most people would like to do something in a reasonable quality patient. Here again, there is a locked dislocation and fracture. If you want to operate, this is a, if you see, this is the bicipital groove and the fracture is significantly displaced. I don't have other x-rays, but if I show you other x-rays, there is a significant, there is no contact between the two fragments, and there is a buttonholing of the shaft through the muscle. So there is, on the lateral view, there's hardly any, there's a huge gap. So most people will like to get at least some contact between the two because the patient is quite active and functional. Now there is a lot of comminution like this with dislocation, then you do operate. But if you're thinking something like this, this, I think we can treat them non-operatively. And that is the whole beauty of PROFA trial is you can back your decision with evidence. And a lot of the fracture dislocations or a lot of the fractures you will see, you can tell that this is significantly displaced and there is a very little chance that this will go into union. You can operate. And a good thing about shoulder surgery, you can wait 4 or 5 weeks and see how it's going. You can still fix them at 3 to 4 to 5 weeks.
Dr. Pandey, can I say that probably COVID will prove that PROFA trial is correct? Because under compulsion, we will be probably operating less and less, and we'll be surprised that it works. You think that change is going to happen?
Dr. Maheshwari, it's the other way around. If you look at these x-rays, they would have got nailed or plated. So it will prove that, you know, non-operative treatment works. So you're right there, yes.
I think, see, when the recruitment for PROFA trial came in, it is a pragmatic trial. So basically, if you are in confusion whether to operate or not, only those groups went into recruiting either operative or non-operative. But here now, that's the same scenario. Whether you are restricted, you will be operating only the very bad displaced fracture dislocation now. anything which is amenable for conservative management or maybe minimally invasive operation or a possible later replacement would be going for an automatic enforced for a trial by COVID.
Yeah, so COVID is forcing us to go to profile trial.
Is a COVID forced trial. I think it's very, very important to collect all our cases in this time. What is their progress in 6 weeks' time? I have seen one patient, I've sent them, explaining the risk. We'll see in 2 weeks. The lockdown is increasing. So I say, okay, see in 4 weeks. In 6 weeks' time, if I see the patient, I might need to review my decision.
Anybody else?
Yeah, I think one of the things which we are forgetting here, most of the senior surgeons and some the people who are experienced, they kind of believe in Profertile more than the younger lots. And I have faced this problem with my fellows and my juniors.
Yes?
Can't hear. Can't hear, Abhik.
Abhik?
So I think the people who are
Poor connection.
I think it's,
so what Abhik is trying to say is that younger generation is more hooked on to surgery. If that's what I got it correct. I think that's very, very, usual because they are pushed into so much into surgery. We have so many courses. We are all the time talking about surgery. Even if Profertile trial is come, which is evidence, we don't want to believe it because it works against my basic thinking of operating. But I think COVID will probably prove it right that now because of your own interest, you decided to go into non-operative and it worked. So profile or no profile, it is proven to you indirectly that it works for you.
So there
but
are many,
I see them wearing PPs and doing nailings and platings.
Yeah, so there are many quotes which are floating around. Yap mentioned one fantastic one: nothing spoils your results more than a proper, long, well done follow-up.
Yes.
So, and the second thing they say is nothing in this world can't be made worse with surgery. And the third thing, which one of my boss used to say, it takes 5 years to learn how to do surgery. That is the residency program. It takes 10 years to learn when to do surgery, but it takes 20 years to learn when not to do surgery. And I think that's an important message.
Yes,
Right.
Can I ask a question?
Yeah.
Yeah, a question for Radhakant. A case, because there is a time after COVID. Your younger colleague of 45, coming back from ski holiday, has a 4-part fracture, not very displaced, but he's only 45 and he would like to have a full range of motion. What would you do?
So if it's not very displaced, Dr. Williams, I'll treat it non-operatively if it's in a roughly reasonable position. But nobody can guarantee that after surgery you will get perfect result. That is the other problem. Now, so if it's a intertrochanteric fracture, you do a DHS, I can reasonably guarantee you that you will walk and do pretty good. Whereas in proximal humeral fractures, such guarantees don't exist. And if it's a reasonable, like a fracture like this here, which I'm showing on the thing, or this one, I would treat this non-operatively in a 45-year also. However, I see your point. Younger patients, you have to individualize. And also, if it's minimally displaced, I generally use minimally invasive surgery so that I don't cause any further damage to the soft tissues than what already exists. So it has to be individualized, but I will have no hesitation in treating a 45-year-old with minimally displaced 3 to 4 part fracture of a proximal humerus non-operatively.
Dr. Pandey, you want to say something?
Yeah, another question, because if we talk about proximal humeral fractures, we have 3 important factors. That is the patient, the surgeon, and the method.
Correct.
And definitely, and that is probably the reason that younger surgeons are maybe getting more aggressive. The methods, the implants are much better. You are extremely experienced in fracture surgery at the proximal humerus. If you have, and you showed very first example of a poor outcome after operative treatment, but what is actually your opinion, properly done proximal humeral fracture fixation? Are they generally reaching a nearly normal range of motion, or is it worse?
So if it's a two-part fracture, if it's a fracture like this or this, they do very well with fixation. The problem happens with four-part displaced fracture where the tuberosities have gone haywire. And that's where the insecurity of surgical fixation comes in. And I know everybody is plating, doing proximal humeral plating, and it's supposed to be a very good implant. I have my reservations because it doesn't consistently give good results all the time in four-part fractures. Two-part fractures, you can do whatever you want, it gives good. But if it's a four-part fracture with significantly displaced, sometimes it gets excellent results and sometimes it doesn't. And yes, it depends very much on how good the surgeon is, how experienced the surgeon is. But I also have a little bit of concern about the implant itself, because if it's a four-part fracture, once the fracture starts to heal, there is some collapse of the proximal humerus. The head starts to collapse. And the screw, because it's locked in the plate, it goes into the joint. So screw penetration is a lot more than people report, and reoperation rate to take the screw out is also significantly higher. So for two-part fracture, fantastic. You can plate it, no problems. Three-part fracture, still, it's not